Okay, we're going to go ahead and get started. Hello and welcome, everyone. My name is Michelle James, and I am the Senior Director of Alumni Engagement here at Emory's Rollins School of Public Health. Today, we are very excited to continue our new webinar series, Our Public Health Future Starts Now. The series was created by our Rollins Alumni Board and offers public health students and leaders an opportunity to highlight advances in technology and consider how we use these advances to help shape the future of public health. In our first session last fall, we discussed how public health can address future outbreaks, chronic health challenges, and even climate change through data, biotech, algorithms, and non-traditional partnerships. And that session is recorded for your viewing pleasure if you'd ever like to watch it. In today's session, we will explore the transformative power of generative AI in delivering public health and health management solutions, and how this technology can revolutionize the way we address health challenges at a local, regional, and global level. At this time, I'd like to turn the program over to Niles Friedman, Rollins alumnus and current Rollins Alumni Board member and visionary for this new series. Niles is a founding executive advisor with Start Insights, where he specializes in creating and growing businesses with core functions within organizations. In this role, he works to build strategic collaborations across various sectors, industries, and geographies through his work with startups, C-suite executives, public sector administrators, and nonprofit leaders. And with that, Niles, I turn the program over to you.
All right. Thanks, Michelle, and welcome, everyone. We're really excited about this session today. Love to hear the background on this. We're really just inspired by, I think, where technology is going. I mean, this was all happening sort of pre-COVID, sort of post-COVID. There has been just an influx of innovation around tech and data. And, this series is really trying to figure out, like, how do we elevate these topics? How do we talk about technology? How do we talk about data? How do we talk about innovation? How do we ensure that we sort of tie the thread and pull the thread over to what is the future of public health? What does that mean for professionals? What does that mean for alumni? What does that mean for students? What does that mean for careers? What does that mean for the diversity of what public health can look like, in the next couple of decades, given all of this innovation that has influxed into our space in the last, I would say, probably 5 years in particular. The other part of this, which I really want to emphasize, is that this is a new series. As Michelle mentioned, we launched our first session in October 2023. We've got 2 more lined up in April, and then we have a really bold agenda for the next academic school year. But we want to make sure that this continues to stay really relevant and is adding value back to the alumni community for Rollins. So we'll be sending some follow-up for those that attended today and that signed up for this session so that we can make sure that your voices are heard. So if you have ideas, if you have topics, if you have speakers you'd love to hear from, we want to hear your voice, and we want to make sure that this series really stays relevant. Speaking of alum, Dr. David Bray has been an amazing collaborative partner on this series to get this off the ground. His level of expertise, his enthusiasm, his ingenuity over the last couple of months and really getting this series off the ground has been amazing, and just want to acknowledge that, David. He's going to be facilitating this session today on generative AI, as well as being an active contributor. And really excited about what we're going to be doing with David over a few sessions over the next couple months. So with that, I'll pass it over to Dr. David Bray. Thank you, sir.
All right. Thank you, Niles, for that generous introduction. And thank you, Michelle, and everyone with Rollins School of Public Health and Emory University for the series. So yes, this is a chance for us to do what I consider to be jazz. We have 2 other impressive guests. I'll let them share a little bit about themselves when we get to the why does this matter first part of the opening. But this is really going to have a chance to sort of be a chance to be a jazz trio, and then also invite questions from both the audience that's online, because that's when it really gets to be interesting when we explore this space together. And so in going to each of my colleagues as part of this trio and what we're exploring, I'm going to ask each of them, why is this so important for us to explore the intersection of healthcare, public health, and generative AI? They'll each give you their thoughts. And I will set the stage by saying, at least from my perspective, there was a survey that was done by George Mason University that looked last August and September at the current state of national AI strategies around the world. At the time, there were 54 different national AI strategies for different countries, and not just in the North America and Europe regions of the world, but also in Asia, Africa, South America, and Oceania. And what was interesting is almost none of the 54 national AI strategies tackled the issue of healthcare and AI. And you consider that we just had this thing called a pandemic, it might be an important issue, but it seems like for whatever reason, tackling the issue of healthcare and AI seems a little bit thorny. And so with that, I'm going to go first to Perry and then to Chad as we try to explore this interesting space together, both to introduce themselves and to dive deeper. So first, Perry, over to you both to share a little bit about yourself and why is this so important?
Thanks, David, and to Michelle and Niles for convening us all here today. So today I come to you as the Chief Marketing and Product Officer for Data.org, which is a nonprofit focused on building the field, a platform for partnerships for data for social impact. And increasingly, with data as the underpinning of AI, that role has taken on, I think, increased importance. So I've spent my career really seeing the power of technology to change behaviors and to share ideas really broadly. I've worked in private sector tech at big companies like IBM and startups and academia and the social sector. And throughout, I've been able to take part in a world where everything starts as a toy, right? I was really sure nothing would evolve beyond the Trio. That was my favorite phone ever. But everything seems new and crazy like a toy, and then it ends up being a valuable tool for living our lives safely. Public health is obviously no exception here. For well over a decade, public health tech, including apps for food inspection, poison control, HIV transmission, and air quality. I mean, air quality is now just on our general weather app, have become part of what we understand and do in the world. But then 2019 comes, right? And with the accelerating event at the end of 2019, early 2020 of COVID-19, which showed us that these point solutions, these individual understandings, are pretty useless in a vastly interconnected and global world. So data from the point solutions has to come together for public health goals at scale. And that's the big why. Unless we work together to make things portable, to make things interoperable, we can't count on disease to respect the borders of our technology limitations. We have to go beyond. So for Data.org, that meant we developed a global collaborative called Epiverse, which develops distributed data analysis tools and an open source software ecosystem. We work with universities around the world on that. The first 3 trace tools are digital public goods, have been certified and downloaded more than 14,000 times. But the topic of today is generative AI. As I said, data is the underpinning for AI. You got bad training data, bad data, garbage in, garbage out. We all know that. So we recently held a global generative AI skills challenge where we're really trying to surface what are the great social sector uses of generative AI, and one public health solution came to the fore, which is about women's reproductive health, led by the Mahila Foundation in India. So really excited to be here today. We think, that data and AI are a core underpinning of public health, working together, but we have to, in some ways, not only change what we do and how we do it, and the why is we're all in this together. Thank you.
Excellent. Well, thank you, Perry. And so, Chad, with that remarks from Perry talking about the importance of data, specifically interoperable data, and how it actually changes how you do what you do and the processes involved, be interested in your thoughts, Chad, as to we look at the topic of healthcare and generative AI. Why is it so important that we get it right?
Well, thanks, David, and thanks again for allowing me to be a part of this great conversation this morning. Just a quick introduction. Chad Vandenberg, I serve as the Chief Quality Patient Safety Officer here at UC San Diego Health. I'm also a very proud alumni of Rollins School of Public Health, and really excited to be a part of this conversation. So to your question specifically, we think about the possibilities in terms of 3 sort of broad categories. One is thinking about the administrative burden associated with understanding how we're delivering healthcare. We spend, on average, about 50% of my team's time diving into the record to try to understand what is happening in that delivery process. Generative AI and large language models offer great promise in that space. But from a big macro perspective, we are actually in the 25th anniversary of To Err is Human. And in these past 25 years, I would suggest that we have made some progress, but not nearly enough. A recent article came out published using CMS data to get to the data point that 1 in 4 of those patients in our healthcare delivery system are experiencing some form of harm during their healthcare journey. This is 25 years after that seminal publication. So as I talk about this, both within our organization and then outside of it, I think of this as we are on the cusp of a brand new way of looking at quality and safety in healthcare. Because to frame it out and to go back to where I started, there is a lot of administrative burden in healthcare, and I think we can solve some of that through these technologies. There's the capability of using the technology to detect when things are going wrong in that healthcare delivery process. And begin to perhaps bring deeper learning to the data we already have at our fingertips. And then the real promise is in prediction. And how do we use that data, use these models to understand who's at greatest risk for an adverse event or some process to go awry in the healthcare delivery system, and then intervene. So there were a few years ago, we did a little quick analysis. There were over 9,000 studies in healthcare that referenced AI or LLM as a promise and as a topic of consideration, but only 4 of them were tied directly to outcomes. And that's where we want to go, is to leverage the technology to really influence outcomes for our patients.
Well said, Chad. And if I can ask you a rejoinder and then go to Perry. One that I love that you talked about, but one, it's about thinking about the healthcare delivery and that it is a process. It is not simply a single thing that you do, and then the tying it to outcomes. And so I'm wondering maybe, Chad, if you can dive a little bit deeper as we think about how generative AI is going to be employed. How, can you give us some sort of details on what folks should be thinking about to make sure that it's both patient-centric and provider-centric? Because obviously we could also see cases where maybe generative AI is not that. So maybe if you could tell us sort of like, what should people be thinking about? And then Perry, I'm going to go to you also for a rejoinder on that, thinking about lessons from the Epiverse about people-centricness and what was learned there. But maybe Chad, if you could go first, how do we make sure we think about how we use generative AI for healthcare outcomes and delivery in such ways that are patient and provider-centric?
You bet. So let's start with making sure that we're actually delivering what we say we're going to deliver. So as we dive into this technology, we explore the different functions and capabilities of it. It's imperative that we both study the models that are deriving these predictions, deriving these outcomes to guide our care processes, and then continue to study them over time. One good example from UC San Diego Health is we developed a technology to alert providers when certain conditions were present within our patients. We studied that, and then to get back to your question, we studied that over the course of 6 months, realized that it was actually not delivering what we thought it would do. This was going on in the background, what we thought it would do, and not producing the kind of data that we thought we would generate from it when we initially proposed the hypothesis of the model. And it's that diligence of making sure that you're studying the model, you're studying the production of whatever it's delivering, whether that's an alert or a signal or a report, and then refining it over time. And it's really critical that we do that because at the end of these care processes are our patients. To bring it back to that, everything that we're doing at UC San Diego Health is centered around our patients. So we're not generating sort of new ideas, new toys, I think was a sort of a phrase used earlier, for the sake of toys. We are trying to solve real problems for our care delivery processes. And it's with that in mind that we are cognizant of what these models are producing, what are the information we're getting out of them, and making sure that we tie them back directly to the patient. To give you one example, we have just recently published, Dr. Shamim Nemati, Dr. Gabe Wardy had developed a sepsis prediction model. And it's critical to differentiate this model from there are many, many models out there around sepsis, a very complicated disease that has some early clinical indicators to signal the disease progression, but those are often not in sort of concert with the physician sort of diagnosis, and determination of sort of what to do next relative to the patient. These two leaders here in our organization developed a model, refined that model over time. We've deployed it in a way that is directly in line with our operational care processes in the ED. And with that signal, with the integration into our operations and how we're working through our care processes in the emergency department, we have demonstrated a nearly 20% reduction in mortality through the development of that model, the early detection, and therefore the early intervention of treatment relative to that disease. So it's one example, but it's also a really nice bellwether for us that we know we can do it. We know we can integrate it into operations and integrate it into those care processes, and always keeping sort of the patient in mind as we do it. So,
love it.
Yeah.
And I love how you showed that it really is thinking about what is the outcome that you want to see happen holistically for the patient, for the delivery process. And as you mature those sort of ideas that toys become tools, making sure that it's matching what you want, and if not, circling back and doing iterative learning as a result to make sure that it's fit for purpose for what you're rolling out. So I really appreciate that, Chad. And Perry, I figured maybe if you could share from data.org's perspective, that would be great, where you can sort of share both either lessons learned from the Epiverse activities or other data.org efforts about how you make sure that data is people-centric and community-centric and how folks are involved with it.
Great. Just to comment briefly on Chad's remarks, two things he said really resonated with the iterative design and going back, and human in the loop, that you're incorporating the healthcare providers' perspectives, I think is really critical to what you do and how we do it. I don't know a doctor on this planet who doesn't complain about EHRs and the impact on their work. So the more you can stay close to that system and figure out what are the pluses and are the minuses, and some of the known problems way before AI of normative defaults in those systems that are creating disconnects around patient care is really important work, and congratulations. So from the data.org perspective, really focusing on the what, one of the things we really focus on is localism. How do we understand that local context is critical to what you do, and getting more and different hands behind the keyboard? We did a 2022 report called Workforce Wanted when we saw the need for 3.5 million data for social impact roles in developing countries alone. So really thinking about what are the ways that you have local people designing systems. So to bring it to a story level, so one of our grantees from our Inclusive Growth and Recovery Challenge was Solar Sister. And initially, a lot of the work they did around clean light and energy for women in sub-Saharan Africa, women's entrepreneurship, it's right at the nexus of climate, entrepreneurship, and sustainability. So it's really a wonderful initiative. But one of the challenges was the first idea was that they should do solar panels. And the solar panels, great, that's terrific. They're bigger, they're more efficient, they bring more value. Funders love to see that high level value. Well, panels need to be cleaned, and cleaning is women's work. And men don't want to get up on a roof, and women can't get up on the roof and do that cleaning. So the organization pivoted toward stoves and lamps, things that the women could control. So really designing with the local context in mind is so important when you think about the solutions you're building. And that's what Chad's referencing, thinking about the doctors and patients on the ground. So similarly with this Meinem Hilla Foundation around generative AI, to steer it back there, really working to make sure that these models or LLMs are developed in local languages and contexts, because topics of sexual and reproductive health can be very taboo in certain cultures. So making sure that people have the right relevant information in the right language in the local context is really critical to making sure that people are able to use it. You can't deliver flyers in English or even the dominant local language and deliver them door to door to people and expect that that information could even be looked at in a public setting. You have to think about what are the ways that you can really develop a workforce that can do this. So they're building prompt engineers who craft effective prompts in local languages, and also AI-assisted healthcare workers, which again, to your point of human in the loop, they can go back and provide medically accurate information to women who lack that information. And they're trained both as healthcare professionals and in the community's cultural context, aware of common misperceptions around sexual and reproductive health. Thank you.
Love it. I love it, Perry, that you pointed out being aware of both the local context in which you operate, the sensitivities, the language that is so key for how we make sure things are both people and community centric. And it resonates with an experience I also had. Back in 1998, I built a computer model of the spread of HIV/AIDS in South Africa and was actually on the ground in Cape Town in South Africa. But what was disappointing was the way people got their information is they didn't talk about HIV/AIDS. And when I actually had a chance to interact with high school students, they said, we went to the local library. That's the only place where we get information. And so being aware of what is taboo, what can and cannot be talked about back in 1998, HIV/AIDS was still perceived by some to be actually a Western myth and not actually exist. And so being aware of some of the sensitivities as well when we roll things out is so key for public health. And I really appreciate you underscoring that.
Unless
Go ahead. Go there.
unless we see these as only as like distant, faraway lands where local and cultural context, the hierarchy in your average US-based research hospital would make an Elizabethan court look casual and, where oncology sits versus primary care versus, those palliative care nurses versus it's a complete, dramatis personae of people and roles. So it's equally important for Chad's work to think, what are the cultural contexts that exist in an R1 research hospital, and how do you navigate around them to make sure people are both empowered by technology and aware of sort of their social and cultural understanding to make people make change?
Absolutely. And I think to even underscore a little bit more about what you're saying here at home in the United States, when COVID happened, if you recall, initially, the United States government, the federal government, was giving funds to the states to roll out testing locations for COVID. And when they rolled it out, a lot of states decided to place their testing locations where a majority of people lived, which was well and good, except for some cases in the southeastern United States, for if you were Black or Hispanic, where you lived and where you worked was 30 to 45 minutes apart. And if this was a testing facility that was open Monday through Friday during normal work days, there was unfortunately, it created the false perception, unfortunately, that somehow these groups were hesitant to get tested when in fact the testing site was in the wrong place. And so understanding that, and then it actually repeated itself about a year later when they rolled out for the actual vaccine for COVID. If you remember, initially you had to be above a certain age requirement. And then you had major news publications, unfortunately, running headlines claiming again that there was somehow hesitancy in minority populations for getting the COVID vaccination, when in fact, unfortunately, for historically unjust reasons, if you're above the age of 60 in the United States and southeastern United States, you are just more likely to be Caucasian and not Black or Hispanic. And so understanding the data and understanding what it tells can also then say, well, we shouldn't have an age restriction for the vaccine because that actually turns out to be the very wrong thing to do. And so I think that is so key. And I can see Chad is ready to actually join in. So Chad, jump on in.
Yeah. Well, I just want to play off those comments because just to give you a local example of one of our experiences here at UC San Diego Health, we were one of the first in the state to roll out that mass vaccination location. A fantastic partnership, the great vision of our CEO, Patty Mason, but in partnership with our county, the San Diego Padres to create the physical location for that drive-through. And we served a lot of our community. Hundreds of thousands of folks went through our drive-through to get their vaccine and create a safer community. But we discovered, again, back to what the data tells you, we discovered very quickly that the demographics of those who were able to take advantage of that were folks, in fact, driving hours because we were one of the first sites in the state of California to come down to get vaccinated with obviously greater means to be able to do that. So we pivoted. We kept that vaccination site open because we were serving this state and our community very well through that. But we also then very quickly developed a mobile vaccination unit where we could use the data. In the state of California, we have something we call the Healthy Places Index, which gives us some context for those who might be at greater need or historically disadvantaged in our healthcare delivery structures. And we brought the vaccination clinics to them, to those communities in our region. Because of what the data told us. We were doing good, but not doing good for all those populations that we had intended to be able to serve through this mass vaccination site as well. So your point is spot on, David, it's you got to use the data, you got to study what's happening in the care delivery processes to understand how to pivot to, again, serve those patients, serve those communities as best as you possibly can.
Well said. So now I'm going to go to one. I would just say for folks online, please provide your questions either through the Q&A function or put into the chat. But in the interim, I'm going to go to Perry and Chad because Perry threw down the electronic health record, the fact that it's sort of the bane of a lot of people's existence, but we need it for the data. So maybe Perry, I'd be interested in your thoughts, and this is more speculative, consider how can we make electronic health records and electronic medical records in a way that is useful in a generative AI era, both for the person who is providing care or the group of people who are providing care, and also for the patient. Because we could imagine a future in which, in the near term, maybe 6 months from now, maybe 12 months from now, patients are going to have AI apps of questionable quality claiming to be their AI health assistant. But the question is, at the same time, as we just talked about the importance of data, I'd be interested, Perry, in your thoughts. Just imagine a future in which we can make things with the electronic health records more accessible to providers and patients in a way that serves the community.
Let me start dystopian and lighten it up from there. So,
Sounds good.
what I fear is we're heading to a future where, the wealthy have concierge medicine, that they have their privilege to interact with humans. We can already see this in airlines, right? If you have a certain amount of status, you can actually reach a human. If you don't, good luck to you. You will be in a chatbot heck for a really long time.
Dante's 8th circle that he didn't tell us about.
Exactly. So that's what I really hope does not happen, is that disparity of who gets AI generated healthcare advice and who gets access to real humans that you can ask questions of. I do think there's an opportunity to augment humans with AI that could be tremendously powerful for all healthcare, consumers and patients. That'd be really valuable. But how do we avoid that future? I think it's about thinking about the idea of localism and local context being at the core of what you do. I think Chad touched on several ways that he and his organization are working on this to go back, iterate, and check and see how things are used. And I would say, think about the use rather than the cult of data. I probably have seen so much data collected that is never acted on because some day maybe we might need it. I've gotten, I think in the last week, request to rate my dry cleaner, request to rate my purchase of a one-off gift for a child. Every single interaction now requires and God forbid you click the first button because then you're going to get 9 more. So I think being really mindful about what we collect in terms of what will be useful to us. I think there's tremendous power in small data. Obviously, we want to see the larger healthcare trends, but we may be able to anecdotally validate our anecdotal experience through data to understand it, as well as use big data to discern larger trends that may be invisible to us. So I guess it's about how and who creates the systems, how, as Chad points out, those systems are vetted, tested, and reviewed, and how we think realistically we're able to act on and use the data versus sort of the cult of data collection without thinking about it. In terms of generative AI, I think it's really important to think about to validate that data. What are the ways, we know that it's been collected? How do we make sure to bring in I wonder if there's going to be a system where there are third-party validators of data integrity. Now we do it for cleanliness, but are there going to be similar systems around? Are they representative? Are they ethically collected, and what those will look like? Thank you.
Well, and I love what you said about that, Perry, and as I get ready to go to Chad, because in some respects, you touched on almost every discipline of public health, ranging from biostatistics to behavioral science and understanding that, health policy management, epidemiology. In some respects, you almost need every discipline to come together because no one discipline has the right single lens. It's really, like you said, thinking about the different lens and also saying sometimes we don't need to collect all this data if it's actually not benefiting the patient. So with that, Chad, Perry has thrown down the gauntlet. It's now your turn to sort of say, what do you think about how we can use electronic health records in more people-centered approaches in the Gen AI era?
Yeah, for sure. The promise of the EHR is, I think, still to be realized. And again, maybe this is the turning point of being able to realize that, where still today, over 90% of what is in the EHR is in unstructured text. So we of course sort of populate things around height and blood pressures and things that are in discrete fields that are very reportable. But again, most of the data that is in the EHR is in unstructured text. So the promise of LLM and AI is that we can now read that in a different way more efficiently, bring together context relative to those notes that are throughout the record, and then begin to frame out that context for our providers, for our care teams, and then most importantly for our patients. So let me give you a couple examples of how we're doing that locally. First, we launched a pilot recently published around it where we're an Epic client, and so we get a lot of what we call my chart messages. These are communications from our patients to the providers, asking questions either in anticipation or in follow-up to visits that they've had with that provider. And that leads to, from a provider perspective, a lot of what we call pajama time. That is, outside of the clinic or outside of their shift, the time they spend caring for these patients through these interactions through MyChart. And we sought to create some efficiency in that to try to help our providers really minimize that pajama time. So we leveraged AI, LLM, are still doing this today. This is one of those where we are iterating and we are learning and we're testing. But when we get those MyChart messages for a select group of our ambulatory providers, we're leveraging the technology to generate the response. It's looking at context of the question, looking at context of the visit that was just prior to that, bringing to bear some other important information that the provider would ordinarily reference in their response, and generating a proposed response. Now, that proposed response cannot go back to the patient without the provider's review and authentication and making sure that that's exactly what they want to communicate. But the promise is that we can maybe cut down on some of that time that they spend generating these responses. When studying it, we found that our patients preferred a really long response. They felt that long to the survey fatigue potentially, but when we surveyed our patients, they felt like the longer the response, the higher the quality. So obviously, generative AI and large language models are able to generate this, bring a lot of context to bear, generate long responses. It also supported the provider again, ability to kickstart that response. Well, two things that came out of that study. First, we were actually not reducing the provider's time. We were maybe generating a little bit higher quality response, but they were still spending a considerable amount of time sort of finessing the response before sending it back to the patient. So that's an ongoing study that we have here at UC San Diego Health, is figuring out how do we leverage this. We still see the promise in trying to reduce the time that the providers are taking to generate these responses and trying to provide a higher quality response. But we're still in the testing and sort of iterative process of that. And again, getting both the providers and the patient's feedback on how this is working for them. Again, it's back to that local level. Those involved in the process and closest to the process are the ones that should be guiding sort of our iteration of it. But that's just one way that we're trying to, again, leverage AI and LLM to generate efficiencies for our providers and meet the needs of the patients in the same space. There are some other things that I will just touch on, and maybe we can come back to in a moment. But we are also looking at technologies where, again, we can bring the focus back to the patient. So we, because of the AHR, we have providers, nurses, pharmacists, physicians, certainly advanced practice providers, spending a lot of time keystroking in the encounter they just had or the impression they just had with meeting with the patient into the EHR. And that it takes up a considerable amount of their time. And our hope is that through ambient listening, through the large language model technology, that we can begin to generate notes, again, highly complex, sophisticated, complete, accurate notes through ambient listening and generating the initial sort of note for the provider so that they're doing more editing as opposed to initial generation keystroking. Again, it's a promise that we hope to explore and bring to bear because we would much rather the care providers be looking at our patients, interacting directly with our patients, than blending their time with them between looking at the computer and keystroking, turning back to the patient, looking back to the computer and keystroking, and then again, spending a considerable amount of their time after that encounter in what we call pajama time, where they're completing those notes or completing the interaction with the patient through these MyChart messages. So those are just two examples of where we're trying to bring to bear the true promise of EHRs by leveraging the technology to pull out those unstructured text or generate them on the front end so that they are in some structured format, so we can do some reporting and validation and measurement off of it.
Excellent. Well, I appreciate it, Chad, and that's some good specific examples, because one of the questions that we did get from the audience, and you actually touched on it, was to give very specific examples of how it was done and the outcomes associated. We do have two additional questions. One comes from Dr. Santana, and so maybe I'll go first to you, Chad, and then to you, Perry, on what can smaller public health organizations that may not have the internal expertise themselves or capacity to leverage generative AI. So are there suggestions that you have, Chad, and maybe Perry, about where they might either turn to additional support or opportunities to partner as ways to move forward? So first, over to you, Chad, on what can we do for smaller organizations?
Yeah, they're actually, because of the promise and the sort of enthusiasm around this space, there actually are a lot of companies out there looking to partner with organizations to both sort of develop out the technology, support those in their mission to care for communities or patients through like direct healthcare providers. And so we aren't doing this alone either at UC San Diego Health. We have a lot of partners now. I think we're privileged in the way that we are partnering with a lot of the sort of internationally well-known organizations. But there are lots of players in this space, again, looking to help and support the better outcomes for our communities. And so I would start there. I would look for partners, and there are lots of them in this space who are very eager to again develop out this technology to bring it to bear in terms of its full promise. The larger ones that certainly are in this space, you have the Microsofts, you have the Amazons or AWS of the world, but we're partnering with even smaller companies who, again, depending on the application, have a lot of sort of interest in bringing to bear expertise to be able to support organizations. So that would be my advice, is to go out and look for partners in this space.
Excellent. Well, thank you for that, Chad. And Perry, interested in your thoughts, if you've seen places where people can go either for support or partnerships if they happen to lack the internal expertise.
You know, I'll echo Chad's point about the larger partnerships and finding organizations interested in supporting you, but I would actually take a different angle, which is empower individual actors. Generative AI should not be something that's brought to you by Merck or Microsoft. We're happy to partner with Microsoft on our Generative AI Skills Challenge, but it should not only be that. How do we educate individual practitioners about the use and the potential of this technology? So that speaks to maybe getting grants for individual licensing, but getting training, demystifying, because I think it's really important that this technology is done with and not to the populations we hope to empower and serve.
Well said, and I particularly agree with you on it's something that needs to be done with the populations as opposed to. So we did have sort of a jump ball question that maybe I'll go to Perry and chat on as well from another attendee who was asked, are there examples for even just basic healthcare? Are there resources that communities may be able to go to, or is this a gap where we right now don't have trustworthy generative AI that people can go to even to ask questions about basic healthcare? And we keep this in the context that, and I'll just say this for our audience, remember, generative AI is not a tool for assessing fact versus fiction. It is only as good as the training set that it's trained upon, and it can be misused. There are already examples of where we see, unfortunately, realistic looking images, audio content, or video that happen to be fake. There's also examples on the internet, it's been happening over the last 6 to 7 months, where generative AI allows people to create lots of realistic looking web pages that all point to the same search result. And so as a result, our search engines that in the past, 10, 15 years ago, could say the search page that is pointed to the most is probably the most authoritative one. Well, in a Gen AI era, the search page that is pointed to the most may or may not be the most authoritative. And so even absence of Gen AI, when you now type in search results, you need to be suspicious of the first, second, and third search results because they may have been manipulated to be presented to you in ways that are not real. But Perry, and then maybe Chad, is this a case where there are places where people can go for generative AI, even for basic healthcare information, or is this a case where we still have a gap?
I would argue we still have a gap. I mean, the propensity for any sort of large scale, easily manipulable system, whether that's search or AI, to become a dumpster fire is absolute. So I think a healthy level of skepticism. I do think there will be a rise in private LLMs, and that may be collaborative LLMs. I could see a world in which, and again, this is beyond my immediate area of expertise, hospital systems collaborated to develop, trusted data sets that work across, because UCSD and Harvard and UNC have nothing to win by having better access to training data than somebody else. I think it's a collective win if they can use systems like that. So that would be my ideal future, that there's that kind of collaboration around trusted data and LLMs that for organizations to draw from.
Very well said. And I like that you talked about the risk of a dumpster fire. There is a research effort being done by some academics about how LLMs either work or break down or could be abused. It happens to be called Junkopedia. So just a word of caution to folks. The other thing I'll say real quick before I go to chat as well is I won't name the name of the federal government agency. Let's just say they're involved with health. But about a year ago, Vint Cerf, who's a good dear friend, asked me to actually talk to them about what they could do about a future in which LLMs were coming out that would have varying degrees of quality about the health information they provide. And they were very concerned. And so one of the things that I suggested to them is sort of matching what you said, Perry, which is, do we need to have grants that are provided to universities, to nonprofits that can create different LLMs that are using data? Because part of it is having the science, but then there's also the interpretation of the science, which is more normative in nature as opposed to empirical in nature. And then that could allow the population to pick which of these different health LLMs they want to use for generative healthcare purposes, and actually have a requirement that maybe if it's receiving federal funding, there's a bipartisan oversight board so that it's not subject to concerns of political attacks or things like that. But Chad, over to you about, is there light at the end of the tunnel? Are we not there yet when it comes to basic healthcare and advice being provided through generative AI?
Yeah, I would agree with Perry and your comments, David. I think there's a gap there. I think that this is potential future space, but I don't think it exists today. And again, I love your expressions, but I think we should caution the audience and caution those who think about this space to know that these models are generated off of the training data that gets fed into them, and we unless you're certain of what is being fed into them, you need to be approaching them with a healthy dose of skepticism. I do think that there's promise in this space, though, and I'll just point to a couple sort of examples of that. One is we know that CMS clearly collects a lot of data on the care delivery processes here in the US. But we also have two, and there's many more, but there's two major vendors who sort of provide the EHR space for healthcare providers across the country. Both of them have what I'll call large databases around the care that's being provided across the country. And it's those databases that I think could be an amazing opportunity to train models against, to be able to generate, as Perry described, as sort of these partitioned LLM models off of what we can draw a great degree of confidence against, which is historic performance in our healthcare delivery system as captured through our EHR. So I think that's one area of extreme promise. The other is we at the University of California. So we're an enterprise up and down the state of California. We are one location at UC San Diego Health, but there are 6 other healthcare provider sort of campuses, whether that's UCLA, UC Davis, UC Irvine, UCSF, UC Riverside, ourselves. But we also are developing and have developed our own sort of database where we believe that we can test models against, again, to try to train them against what we would consider exceptional sort of care delivery processes, examples of those, with the ideal outcomes generated from them. So at this point, I think there's still a big gap, but I think there's opportunity and potential promise out there to train these local models, we'll call them, against data that we feel like we could have some pretty incredible degree of confidence against.
Excellent. Well, thank you, Chad. And so I think we're getting towards the end of our show before I turn it back over to Niles and Michelle. And so now we're at the sort of how we move forward. And that's where I'm going to go first to Chad and then to Perry. We've obviously talked a lot about how these can be used to focus on focusing on both the delivery and the outcomes, and reevaluating regularly to make sure that how you use generative AI in a healthcare and a public health space is achieving the outcomes through the delivery process that you want, making sure that you're aware of the context in which you're doing it, making sure you're aware of language differences, demographic differences, awareness of the differences in how people work and live. And so now is the question about what can either people who are currently students in public health, faculty in public health, people who have finished graduating with their public health degree and are now looking for a second career, or sort of using generative AI in what they're already doing. This is a chance now to sort of talk about the how and how we move forward. So I'm going to go first to Chad and then to Perry for the closing words before we turn it back over to Niles and Michelle. Over to you, Chad.
Thank you, David. So just I'll do two contexts. One is for those potentially in the audience, either students of Rollins School of Public Health or past students and or faculty related to this fantastic university. The way I would propose we would go, or how we would go forward, is you all possess a great deal of expertise. And as we've talked a lot here about the idea of training models, understanding what the models are generating, what the goals are of those models, and bringing that as close as possible to those impacted by them, whether that's the patients or the providers through their workflows, your collective expertise, either through biostatistics, whether that's through setting up and understanding sort of care delivery processes, whether that is et cetera, you all bring a great deal of expertise. So look to bring that to bear to sectors, and I'll be biased, hopefully healthcare delivery sectors, but there are a lot of other sectors in the healthcare space, and bring those to bear, because we will depend on that collective expertise to make sure that we have trained the model to minimize the bias associated with the data we're putting into it, or the learning that's sort of prompting it. And then understand and study the results and outcomes of it. And that's where I think this audience and those faculty have a great deal to contribute to this space. The other sort of audience that I would say, how do we go forward, which is to Perry's point a moment ago, which is those who are at the front line of the care delivery processes. We need to empower them with this to be able to help train and learn and make sure that the intended consequence of the model, or the prediction, or the outcome of the model are exactly what we would like. So we got to democratize the sort of capabilities so that we can have those at the front line testing different ideas, and doing so in a safe environment where we're not actually impacting patients until we're ready to impact the care delivery processes. So that would be my two suggestions on how we move forward from here.
Excellent. And thank you for Chad. And I really like how you pointed out that there is a great deal of expertise that comes with a public health training, and it can be applied to this in the healthcare space. Could also be applied to thinking about how we do outcomes in food safety or in climate change and actually climate mitigation. Also, real quick before I go to Perry, we did get an additional rejoinder from one of the persons who asked a question about generative AI in a healthcare setting, saying it was about how it could reach underserved populations. I would say to that question, the challenge is it can't replace a human. You still need a human. And I think what we are trying to sort of indicate is use of generative AI to replace a trained human in healthcare is probably not where the state of the technology is at, precisely because generative AI is only as good as what's trained on. And so it's really about thinking about how generative AI can possibly augment humans who are already trained, but it's augmenting, not replacing. And so when we think about how it can be used to deliver and reach underserved populations, in some respects, you got to start with the human denominator. You can't look to the generative AI tool to unfortunately solve that. But as Perry said, we also need to make sure it doesn't become something that's only available for those that pay for the first class ticket equivalent in the healthcare space and not everybody else. So,
and David,
if
I could just tag on to that for 2 seconds, then I'll let you turn it back to Perry. But that's part of the training, right? The training of the model. We understand there's been a historic sort of bias in healthcare. We have this underserved patient population that if you look at outcomes, it really in almost any disease processes have worse outcomes. And we need to be able to use institutions' data thinking about Atlanta, Grady Health System is a great entity that is serving the population of Atlanta, the historically underserved population. We need to learn from those kind of organizations and the data that they're able to generate to make sure that as we're training models and we're thinking about how do we produce better outcomes and better results from these models, that we are appreciating the inherent bias in much of our data. And it's around the inclusion of the service of underserved populations that will help us mitigate it, not eliminate, but mitigate some of that bias.
And what I love about that is, as you pointed out, in some respects, you'll never be able to remove bias because unfortunately it is representative in the data of society, but being aware of it and mitigating it. And Perry also touched on that we may need to have third-party validators that say, is this data representative of the community that you're trying to serve? So with that, Perry, I'll go to you to have the last word about how do we move forward, whether we're public health practitioners, students, faculty, or people who just care about these issues and are passionate about it.
Great. So I sort of 3 tiers of counsel. One is for universities. So how do you collaborate across schools and disciplines in order to bring an interdisciplinary, thoughtful approach to this? We are in uncharted territory with generative AI. So I think the perspectives of historians, social scientists, that should not only live with statisticians, CS, and public health. We need to find ways to bring everybody into the tent to understand the repercussions and the opportunity of these solutions. Second, for faculty, I think this is a little bit of a curveball, but put climate front and center of your curriculum. I think that more than 4 in 10 people live in areas that are highly vulnerable to climate change. The WHO estimates that there'll be about 250,000 additional deaths due to climate change between 2030 and 2050, deaths per year due to climate change. So I think there's so much, this is an immediate and pressing problem. Often when people form partnerships, like, how do we work together? I always argue you need to start with a use case. And I think the intersection of public health and climate change is one where we're spending a lot of time, and it's an interesting one for faculty to consider and explore. And finally, on the individual level, we all know that AI is here to stay with positive and negative effects, and data is a powerful underpinning. How do we, as individual actors, become, they're not going to solve the problem as individuals, but become aware of the trade-offs and repercussions of using generative AI in our everyday lives and in our professions, public health and otherwise. Thank you.
Well said, Perry. And I loved your 3 points. One, of course, thinking about the systems perspective, that it involves multiple systems, not just public health, but multiple systems levels views of looking at it. You probably made a whole lot of environmental public health practitioners' hearts sing when you talked about thinking about climate change. Interesting enough, when we did the first episode in the series back in October, we got there as well, which is climate change and public health increasingly are going to be intersecting. There's some stats that say, including those of us in the United States, but around the world as well, that 1 in 4 people currently on the planet will be displaced from their homes for more than 3 months during their lifetime as a result of some climate-related event. And so that's worth thinking about. How do we involve people that are displaced from their homes and may not necessarily have the resources that people who do have homes to help. And then finally, as you said, thinking about how we can actually use AI to actually uplift humanity in a way that actually fits how societies want to use it, how different communities want to use it, and how different people will reach and approach it in a way that's actually fit for purposes to help them in a more people-centered way. So with that, thank you, Chad. Thank you, Perry. This has been a great conversation. We could easily have probably dived a little bit deeper as we thought about climate change, food security, and other pressing issues, but we'll save that for another day. I really appreciate your expert insights, and I'll turn it back over to Niles. Thank you again for this opportunity to have this conversation.
Great. And I just want to echo those sentiments. Thank you, Perry, Chad. Special thanks to David for just all your work on this session and the session back in October. And that's exactly where, as I was listening to you all, I think this could become its own mini series that's part of this larger structure. We could get into many relevant topics that came out of the discussion today, and we know will be of interest to Rollins alum and students, as well as just the broader public health ecosystem. So really excited about the discussion today. We will be having a ton of follow-up that'll come from this discussion. This is something that we're trying to do with each of these sessions, is a bit of a write-up and just making sure some of those salient points, if you weren't able to attend or you want to reference what was sort of spoken about and discussed today, we'll make sure that that's accessible. And I just want to definitely reach out, and we'll have some follow-up on ways that you can continue to keep this series relevant. This is our second session. You can see in the chat, we've got a session on the 16th, which is going to be focused on the future of space satellites, remote sensing in public health. This is going to be really exciting. Having worked abroad in Africa, the ability to look at this type of technology to support hotspots in rural communities. And then we have a session on the 23rd of April that's going to be focusing on the broader global digital innovation movement and primarily what's happening across Africa. So more to come. Again, thank you all for your attendance today, and look for some follow-up from Michelle and I over the next couple weeks. Thank you all.
Thank you very much.
Thank you. Thank you all for what you do.
Take care.
Bye-bye.